Thank you everyone for joining the National Pancreas Foundation's 2022 Virtual Education Series. The National Pancreas Foundation provides hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Tonight's seminar, please use the Q&A section of your portal to ask questions during the seminar, and at the very end, we will answer those questions. Tonight's topic is burning questions on chronic pancreatitis in children. I'd like to thank the panelists today who are with us from Cincinnati Children's Hospital Medical Center and also from Stanford University School of Medicine. Maisam Abu-El-Haija, who is going to moderate. Dr. Abu-El-Haija is currently an associate professor of pediatrics at the University of Cincinnati, a pediatric gastroenterologist at Cincinnati Children's Hospital Medical Center. She serves as the medical director of the Pancreas Care Center at Cincinnati Children's, the medical director of the Ohio, Kentucky Chapter National of the NPF. She is the course director for the NPF annual meeting and chair of the Pancreas Committee for the National American Pediatric Gastroenterology, Hepatology, and Nutrition. She's also a current board member of NPF and the president-elect for the Collaborative Alliance for Pancreatic Education and Research. These highlight examples of the national leadership position that she serves currently. She is a known international figure in the field of pancreatology, as she has had multiple presentations overseas in countries and societies such as the PEDS GI Elite, the Arab Health, and the GI Conference in Saudi Arabia, the European Pancreas Club, as well as the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition. So I want to thank you all for joining us tonight, and I'll turn it over to Maisam.
Thank you, Trish, and thank you for the NPF for having us all join you here this evening for a wonderful list of speakers, my friends and my colleagues who help me serve patients in the pancreas field and manage with us chronic pancreatitis patients. Today's topic is burning questions on chronic pancreatitis in children. I am going to serve as your moderator, and I am going to have the honor of being here with my colleagues, Dr. Husain, Dr. Goldschneider, Dr. Rich, and they will cover in their own expertise the arenas of chronic pancreatitis management that pertains to them. And as you will see in the seminar, it is a group effort and multidisciplinary care that hopefully would help us advance management of the pediatric patient with chronic pancreatitis. So without further delay, I would like to start by introducing the first speaker of this event, Dr. Sohail Husain, who is a friend and a mentor and very well known in our pediatric gastroenterology and pancreatology field. Dr. Husain is the endowed professor of pediatrics gastroenterology and serving as the chief of pediatric gastroenterology, hepatology, and nutrition at Stanford University School of Medicine and Stanford Children's Health. Dr. Husain, we look forward to your talk. The podium is yours.
Great, thank you for that wonderful introduction, Maisam. Firstly, can you hear me well?
We do.
Great. Well, I have the privilege this evening of providing an overview of chronic pancreatitis in children, and I'll take about 15 minutes to give you a grand scale tour of this problem. I know this is a broad audience of patients, families, advocates, and clinicians from an array of disciplines, perhaps even some scientists who would like to learn about the clinical entity of chronic pancreatitis in children. I will, for this reason, give you highlights of the main points for many of the slides, and we'll try to avoid heavy medical jargon. This is a tall order for me, although it will leak out. I will begin with a classic but true tale of two real patients with chronic pancreatitis. And the cases will highlight the heterogeneity of the disease and the tumultuousness of their symptoms. And it's analogous to the tumultuous times during the French Revolution, shown here from the classic Charles Dickens book, A Tale of Two Cities. Patient or family member number 1 is a 16-year-old young lady who had many episodes of belly pain as a young child. They were ascribed as functional abdominal pain, and in fact, pancreatic enzymes were never checked. She presented with severe belly pain at the area of the epigastrium, right around, you can see my hand here, when she was 12 years old. And at that point, she was diagnosed with acute pancreatitis. She went on to have recurrences and thus was diagnosed as having acute recurrent pancreatitis. She was pain-free between episodes. And around that same time, she underwent a CT scan or a CAT scan. And what's shown first on the left is a normal CAT scan, and the pancreas is shown in the center as a banana-shaped organ. In the normal pancreas, the intensity pattern is homogeneous. On the right is the CT scan of patient number 1, and you can see that there is a vastly different intensity pattern of heterogeneity. Patient number 1 has what's called diffuse pancreatic calcifications, a hallmark of chronic pancreatitis. Patient number 1 also underwent a specialized MRI called an MRCP, and you see massive pancreatic ballooning of the pancreatic duct with large filling defects, which are ductal stones. An ultrasound of the belly, interestingly, was reported as not having visualized the pancreas due to overlying bowel gas, and thus the ultrasound missed all of the major findings from the CAT scan and the MRCP, which illustrates the need to perform more advanced imaging in this case. We'll contrast patient number 1 with patient or family member number 2, who is a 13-year-old lady, also diagnosed with acute recurrent pancreatitis. She has chronic pain between acute pancreatitis episodes. And at age 13, she underwent an MRCP. And shown here is a sagittal section, or also known as a vertical view of the belly. And the banana-shaped pancreas is shown here vertically. There are only subtle abnormalities. And I placed an arrow to point to the mild ballooning of the pancreatic duct. The tale of these 2 patients illustrates the diagnostic challenge of chronic pancreatitis. Both had a history of acute recurrent pancreatitis. Patient number 1 was pain-free between episodes, but had florid pancreatic collections and massive ductal dilatation. On the other hand, patient number 2 had debilitating pain between episodes, but only had mild ductal dilatation. The diagnosis for patient 1 is clearly CP, or chronic pancreatitis, based on the stark imaging findings. The clinical symptoms for patient number 2 would indicate the possibility of CP, but the mild imaging findings make the diagnosis less clear. Here are some questions that arise from the tale of these 2 patients. What is chronic pancreatitis? How does it develop? How can it be diagnosed? How bad is it? And what happens to patients? How do you treat it? I'll tell you about each of them in brief. Here's a technical definition of chronic pancreatitis, which is an inflammatory condition of the pancreas in which development of scarring or fibrosis and loss of pancreatic parenchyma or tissue potentially leads to impaired endocrine and exocrine pancreatic function. Textbook definition. We'll come back to a practical definition in a few slides. How does CP develop? The current or newer data break old paradigms. We used to think that acute pancreatitis and CP are 2 distinct entities. We now recognize, as shown in the cartoon on the right, that in most patients, CP develops from recurrent bouts of acute pancreatitis. what is sobering is that the chances of developing CP rises to about 50%, or half of patients who have had 4 or more episodes of recurrent acute pancreatitis, as shown in the graph, and is attested by data from the international NIH-funded INSPIRE pediatric cohort led by Alia Uch. The progression from first attack of acute pancreatitis to CP occurs in just under 4 years in children. What is shown here in this table is also from the INSPIRE cohort, which is that genetic and duct obstructive factors make up the bulk of risk factors for CP. How can CP be diagnosed? The classic histological features of CP shown here are the hallmark for a diagnosis, but they are rarely available. An operational definition of CP in children is required, and it consists of the presence of abnormal imaging findings, as you heard earlier from the tale of the 2 patients with CP, along with 1 of 3 additional features, including localized pain, evidence of either exocrine or endocrine pancreatic insufficiency that presumably results from destruction of the tissue of the pancreas. Well, about typical abdominal pain in CP, it is usually epigastric in nature, which is, again, if you can see my hand here, intermittent, but usually constant, sometimes intermittent, but usually constant. And the reality is that CP pain can be non-specific, and one should consider non-pancreatic causes of chronic pain, even with a diagnosis of CP. Well, irrespective of its origin, pain or pain syndromes in CP are real, and an important message is that clinicians should not dismiss chronic pain in patients with CP, for example, as hypochondriasis. You'll hear more about pain from our next 2 distinguished speakers. There are many causes of pain in CP, including pancreatic ductal obstruction with increased pancreatic ductal pressures, ischemia or reduced oxygen to the pancreas, occasionally obstruction by large pseudocysts, neural inflammation and hypertrophy, duodenal and common bile duct obstruction. If you're a patient or a family, you may have heard of any one of these. Additional causes of chronic pain in CP include what's involving the gallbladder, something called chronic cholecystitis, bile strictures, peptic ulcer disease, obstipation due to narcotics, irritable bowel syndrome, and an overlay of depression. So how bad is CP and what happens to children with CP? There's a major burden of disease in children. In self-reports from the INSPIRE cohort, 1/3 of children with CP were usually pain-free, but they had episodes of severe pain. And another 1/3 had constant mild to moderate pain plus episodes of severe pain. When asked, how much does pancreatitis interfere with various activities of daily living for a child, such as school, recreation, ability to concentrate, enjoy life, over 1/4 reported that all of the activities of daily living were affected, quote, very much, as shown in the red. How do you treat CP? Well, I would just leave you with 1 slide on that question. The current therapies for CP include several interventions, some of which we'll hear about shortly, some of which will have been covered or will be covered by other National Pancreas Foundation webinars. They include narcotics as well as non-narcotics, neuromodulators, nerve blocks, pancreatic enzymes for insufficiency and sometimes for pain, nutrition, anti-secretory drugs, antioxidants, endoscopic therapy, pancreatic resection, pancreatic duct decompression, and sometimes total pancreatectomy and islet autotransplantation, also called TPIAT. Therapy does require a multidisciplinary approach consisting of a host of complementary providers sitting together at a physical or virtual table. The NASPGHAN Pancreas Committee, led by Dr. Abu-El-Haija and first authored by Dr. Sinead Dyke, will be publishing soon a report on the essentials of a multidisciplinary approach in conjunction with the National Pancreas Foundation. Back to the tale of our two patients. Patient number 1 turned out to have genetic risk factors, a long-standing medication called Keppra that could have triggered pancreatitis, a clear diagnosis of CP with calcifications, and she underwent discussion for TPIAT. Patient number 2, on the other hand, had no clear pancreatitis risk factors, and because of the mild ductal abnormalities in the setting of chronic pain, a diagnosis of early CP was made, and she was medically managed for chronic pain. In this overview of chronic pancreatitis in children, you've recognized that diagnosing CP can pose a tumultuous challenge, illustrated by the tale of two patients. Proper diagnosis requires a combination of detailed clinical data and imaging. Children with CP have a major burden of disease. Pain is a substantial problem, and the treatment of CP in children requires a multidisciplinary approach. And with this, I thank you for your attention, and we'll turn it back to Dr. Abu-El-Haija.
Thank you, Dr. Husain. That was brilliant. That was a 10,000 view, but very, very helpful summary, and it really encompassing a lot of the important aspects of knowing and medical management for gastroenterologists and more for chronic pancreatitis. Thank you. And we will save our questions to you towards the end. So I also would like to remind the audience to submit their questions in the Q&A. Do not wait till the end. We will be filtering them through as they come. And now I will present our next speaker. And our next speaker is Dr. Ken Goldschneider, as the Director of Pain Management Center, Professor of Clinical Anesthesia and Pediatrics at Cincinnati Children's Hospital Medical Center. Ken, you will be talking to us about pain management.
Yes, indeed.
Thank you.
All right. Everybody hear me all right?
We hear you perfect.
Perfect. Well, we started out with some heavy literature. My literary references are going to be less serious. But the problem that we're going to talk about is awfully serious to the kids who suffer from it. And that's the issues of pain with chronic pancreatitis. I don't have any disclosures, but we do talk about medications that are what we call off-label. They're not FDA approved in kids. That doesn't mean that they don't work. It doesn't mean that they're not legal or reasonable to use. It means that there have not been studies done that meet the FDA criteria. And I could talk for an hour about how that comes about, but let's just for legal purposes say that that's the case. And I also apologize. I may look like a transverse tiger. The sun has swung around since we started the lecture. So I apologize if I look striped with the shadows. But let's talk a little bit about the patterns of pain, how they differ between acute pancreatitis and chronic, and why that makes a difference. So with acute pancreatitis, you usually have severe, usually that upper belly pain that Dr. Husain was talking about. Sometimes it's felt in the back. You can have nausea, and you can have changes in the enzymes. Lipase is the one that we think about most. There can be changes radiologically, as he was saying, with the MRIs and ultrasounds. Acute recurrent pancreatitis is the same as that, except the kids feel normal in between. And then with chronic, they can hurt all the time, or it can come and go. And I'll show you the various patterns in a second. But now the enzyme changes and stuff, aren't as dependable. So it becomes a little bit more confusing oftentimes to practitioners who aren't used to working with chronic and various types of pancreatitis, and sometimes to families, because it almost seems sometimes, hey, if the labs aren't off, then there can't be a real reason for the pain. And sometimes that's a point of contention or stress. And I want to clarify that over the next few slides. Why is that pattern important and the differences? Because we treat them differently. Acute pain and chronic pain are different and have different implications for how they're treated. So acute pain adheres to sort of an old-fashioned, what we call biomedical model. And there's a relationship that's really kind of tight between what you see, what you call it, and how you treat it. So if you get new onset of belly pain, there's nausea and the lipase is up, yeah, you might do a few more tests and you call it acute pancreatitis. You treat it maybe with some opioids, some non-steroidal anti-inflammatory drugs. Ibuprofen is probably the best known of those. Yeah, give them some hydration, you support them through it, you distract them, you work with coping skills. And that's the treatment, and then they're better. Now, with acute recurrent pain, it's sort of a rinse and repeat. That same pattern comes, but then there are these periods of time where they're okay and they don't need any particular treatment. Now, chronic pancreatitis changes the pattern. You can have the belly pain, you can have the nausea, but now the lipase may be normal. You call it chronic pancreatitis, but you need a much more comprehensive plan in order to help the folks do as well as they possibly can. Because here's a little graph, little sort of 25-cent graph on the pain patterns. The dotted lines where it starts, you're feeling okay, and then boom, that pain level goes way up and then it drifts back down and life is good for a while and it's kind of down at that zero line, and then it goes up again and it comes down. These big waves with no pain in between is like recurrent pancreatitis pain. Now, the chronic pain patterns are different. They go up, they come down a little bit, up, down, way up, kind of down, little up, way down, but they never quite go away. And just as a kind of a useful comparison, we could spend all day talking about this particular graphic, but over on the right-hand side, you see the words chronic pancreatitis. That's this tidy little label, you know, their diagnosis we're giving it. But in order to get there, we've got genetic things that go on. We have stresses. We have things having to do with our diet, infections, changes in the nervous system, and all these things kind of wrap together to make changes within the body that we then call chronic pancreatitis. But that simple label kind of is misleading. It's much more complicated, but in ways that are really hard to see. Now, this kind of a little more colorful graphic, and it's only streamlined a little, shows that there has to be a balance in the body as far as pain is processed between what's going up from that poor old pancreas to the brain, and then there are signals that come down that help control pain or suppress it and help regulate things. And there are all sorts of different factors, from stress and depression and things that modify how we process things in our brains, to inflammation and changes in the nervous system as they interact with the pancreas or the gut or almost anywhere in the body, really. And this balance gets all disrupted. So we need a long-term pain plan because that's a lot going on. And as you saw from the slide before that one, there's a lot of background, and just taking a pill isn't going to do anything. All right. So we usually arrange regular follow-up because this is an ongoing process, and the adjustments we make need to be followed up on to make sure that we're not running into side effects from medications, complications from the pancreatitis, or anything else. We really work on maximizing return to normal function, because it's bad enough to be in pain. It's worse if you're in pain and you have no life. We do tend to wean off of opioids because when the pain has entered this realm where there's all these neurologic changes, then opioids tend not to work as well, and you start seeing more of the downsides of opioids than the upsides. We tend to continue various adjunct medicines, which I'll get into in a second. And we have to get involved with a lot of the psychological and social supports, because all of those factors that were listed there pounding on the brain and altering the way the brain processes pain are super important. And if we don't address those, then the person is just going to be flat out miserable. And then sometimes this really interferes with the way the kids have functioned. And so we'll often bring in physical therapy to get them up and going again. Now, non-medication therapies, cognitive behavioral therapy, I'm going to leave to Dr. Rich to discuss as part of her talk. But I'm just recognizing that, you know, I think it'd be completely inappropriate to treat chronic pain of any sort without involving the skills that come from cognitive behavioral therapy. Physical therapy, as I mentioned, integrative medicine, things like acupuncture and so on, are always very welcome. But in the medications department, as I briefly mentioned, in the acute and recurrent acute pancreatitis, things like the anti-inflammatory medications, acetaminophen, opioid medications are fairly standard, and that's fine because that's still pain coming directly from the inflammation of the pancreas. But as things start to have those neurologic changes that go along with chronic pain, we tend to lean a little bit more on what we call neuropathic medications. Gabapentin is one that we use very commonly. Tricyclic antidepressants is a group that we also use. And then there are a variety of others that are less commonly used, and I'm not going to get into. But two of them, gabapentin and sort of the newer version is pregabalin, basically think of it this way. They were designed as anti-seizure medicines to calm down overactive nerves in the brain that cause what we call a seizure. They are good at calming overactive nerves that are involved in pain processing. They're a little different. Gabapentin has a threshold for effect, meaning that you have to get to a certain level of dosing before it does much, whereas pregabalin doesn't. Pregabalin, practically speaking, is more difficult to use in kids because it's often not paid for. We tend to use them a lot for neuropathic conditions such as shingles, the pain from shingles, nerve injury, and stuff like that. So some of the changes that we see in the nervous system with chronic pancreatitis pain can respond to this as well. Doesn't interact with other medicines, which is a very good thing in this case because a lot of times these kids have to be on several medications, and it's nice not to have them interfere with each other. It has a list of side effects like every other medication, and we use them very carefully because we don't want it to run into mood swings and feeling dizzy or sleepy or things that would interfere with functioning. Antidepressants we use a little less frequently in our practice because they tend to have a little bit worse of what we call side effect profile, or the list of things that can happen, and also have more interactions with other medications. But they have a place and they can be useful. We tend to use them a lot for headaches, irritable bowel syndrome, and again, for various types of nerve pain for the same basic reasons as I talked about with the other medicines. They tend to make people sleepy, so if the kids are having pain and having trouble sleeping, a dose of this at nighttime can do sort of double duty, because we all know that good night's sleep makes a whole lot of difference in how we feel. But there's more and more evidence saying that a good night's sleep also helps with pain processing and normalizing things in the nervous system. We tend to get an EKG before we start this because rarely it can affect the way the electricity is conducted in the heart and lead to a rhythm problem, which obviously we don't want. But if the EKG is okay, then it's safe enough to proceed. Just a brief look at some of the old, it's an old drug, it's been around for decades, but you can see here's just a list of different studies that say, hey, it has some use for some things, but it's certainly not like game-changing for most folks. Some of the new medications, duloxetine is the one that we use most frequently in this group. It's probably most well known for use in fibromyalgia, but it's also indicated for nerve pain. It can help with mood, anxiety, depression, those sorts of symptoms. And so sometimes, again, double duty is a good thing. So we will use that on occasion. So in short, acute and chronic pancreatitis are different because acute and chronic pain are different. One is more directly to what's going on in the tissues, and the other is more going on in the nervous system and less dependent on what's going on in the tissues. We emphasize the best possible function because anything that goes on in the nervous system needs to be attacked at that level, as opposed to the rest and protect mode that we get into with acute pain. Reference was made to the TPIAT, and obviously there's no time to talk about that, but we have a comprehensive protocol that we follow for that to get the kids ready for the surgery, through the surgery, and recovered from it. And our role in pain management always is safety is going to be number one. We're going to look for pain, function and pain relief together as second line. And because opioids end up doing more harm than good for chronic pancreatitis, we tend to wean those down and then use them if there is an acute flare, of course, on top of it. And with that, I'm going to turn this back to Dr. Abu-El-Haija.
Thank you, Ken. This was amazing. And to put it all in 15 minutes was really, really great.
Hey, Guy, I'm sorry. May I go back for just?
Yes, please.
Please. I forgot. Sorry. Here we go. Everybody, I made a couple of videos, and these are a couple of QR codes. If you're interested in flashing them, I may be able to figure out how to put them in the chat. Actually, the chat won't work. Anyway, I just stalled. Anybody who wants to take a picture is welcome to. These will lead to a couple of videos, one that talks about sort of the biology and the pathology of abdominal pain, chronic abdominal pain, and then one on the differences between chronic and acute pain.
Thank you, Ken. This is very useful resources and information. I want to thank our speakers, the first two, and before I introduce our last but not the least speaker of tonight, I would like to let the audience know we get your questions and we will attempt between us as speakers to answer them in typing the answers in the Q&A, and then eventually we will read some of them live depending on how much time we have. But they're great questions so far in the Q&A session, so keep them coming, please. Our next speaker is Dr. Kristin Rich, who is also a colleague and an integral member of the pancreas and the pain management team. She is a pediatric psychologist, assistant professor of pediatrics at the Division of Behavioral Medicine and Clinical Psychology at Cincinnati Children's Hospital Medical Center. Kristin, take it away.
Thank you. All right. So I would say this is a number one question that I get, and I hope in these next few moments to help everybody understand how some non-medication, non-pharmacological interventions can help in chronic pancreatitis. So we, as other speakers have said, we know the pain is real. And I think the role that psychologists or mental health providers can play is because we know that the mind and body are connected. As Dr. Goldschneider mentioned, all pain is processed in the brain. And pain can be stressful. And psychologists play a role in helping with managing stressful situations like having chronic pain. So we know the impact of pain is wide. So for many children, the ability to attend school consistently is disrupted, or the ability to keep up with their work and academics is challenging. Many children are unable to participate in as many social activities as they may want to, or extracurricular activities due to the recurring and unpredictable nature of their pain. Also know their ability to participate in family activities or even family interactions can be disrupted. Mood can definitely be affected in terms of sadness, worry and anxiety, frustration, hopelessness. And we know that sleep patterns can be disrupted, all things that psychologists intervene on. So cognitive behavioral therapy, or CBT, is what I'm going to be mostly speaking about today. The goals of CBT are to improve coping skills as well as reduce the impact of pain on a child's life. I will say it is not magic. It is not going to take pain away. If it was, a psychologist would be very wealthy, but it is meant to help reduce the pain experience, ease the burden, and ease the suffering. It is delivered by a trained psychologist or mental health professional. And we know from many research studies that CBT is one of the best treatments for chronic pain, and better yet, it has no side effects because it's something that we do through discussion, communication, and practice. So we think of CBT as essentially a toolbox, and the coping skills and components of CBT are the strategies and tools that we hope people kind of learn, take on, and find benefit from. So I will talk about each of these, but as a summary, it's education about the pain experience, relaxation, activity pacing, thought changing and challenging, distraction, as well as what role the family can play in supporting the child. How can we modify the school environment to help the child be most successful, sleep hygiene, as well as healthy lifestyle habit modification. So when we think about the acute pain flare-ups, one of the most effective and can be one of the most helpful interventions is distraction. So as Dr. Goldschneider was discussing, all pain is, the pain is sent up from different parts of the body and processed in the brain. And so the brain can only kind of process so much at once. So distraction is a way of competing for the brain's attention and can dampen or temporarily reduce the amount of pain that is experienced. So as I always say, distraction is not created equal. So distraction that we consider active takes a little bit more mental energy and effort. So these are things like puzzles, an interactive and engaging video game, or a conversation with a family member or friend. Then there's also what we consider passive distraction. So this can also play a role, but things like watching TV or something on Netflix or YouTube isn't going to require as much brain power and may not be as effective. So there are roles for both, but it's an important thing to point out. Some families find it helpful to come up with a list or a jar of different distraction ideas in advance, so that when a flare-up occurs, when pain is starting to escalate, you don't have to spend the time trying to think about what they can do. They can just reference some ideas that they've come up with in the past. These are the relaxation strategies that we most often teach in CBT. We like to teach a variety so that people can practice, try out, and see which ones fit best for them. So examples are diaphragmatic or deep or belly breathing, progressive muscle relaxation, imagery or visualization, and mindful meditation. And later on in my presentation, I will talk about how to access some of these relaxation strategies. Other tools that can help in an acute pain situation are things like essential oils, massage, heat in the form of a heat pack, hot bath or shower, as well as a TENS unit, which sort of works similar to distraction in that a vibration sensation is delivered, and that ends up competing with the brain's attention for the pain signals, and can sometimes result in some temporary lessening of that pain experience. So when we talk about chronic pain and chronic pancreatitis, these are the core components of CBT, and I will briefly discuss these so that you have a sense of them. So education is a really important, crucial first step. A lot of times kids experience pain for so long, they go to a lot of physicians who say, yes, you have pain and here's what to do about it, but they don't really understand how it works or why it works. So what we do is we explain how pain works in the body at a level that the child can understand and eliminate all that jargon and those long words that are difficult to understand. And we also really emphasize how mind, body, and non-pharmacological techniques can help with a physical problem. This really helps with buy-in and also eliminates some of the perception that children and teens may get when they're referred to a psychologist that the pain's in their head. So no, we want to reassure that the pain is real, but here's how these techniques can help you. So similar to the acute pain, relaxation training is a really key component. Some practitioners may do something called biofeedback assisted relaxation training, which is using computer technology to help children or individuals really understand how they can control their body's functions, like relaxing muscles, increasing the temperature of their body through these types of techniques. We also really work on what we call behavioral activation or pacing. So two types of activity patterns sometimes emerge in chronic pancreatitis. So the first may be what we kind of consider underdoing it. So pain is experienced, there may be some fear of pain worsening, so activity is avoided, and then as that perpetuates over time, we end up with disability, meaning we're able to do less and less over time. And part of this underdoing activity or underdoing it cycle also leads to some, decreased quality of life, less engagement in things that really make life worth living and can increase sadness, depression, and anxiety. We also will sometimes see this pattern of overdoing it. And if you have any children who tend to be high achievers, who like to do a lot of things and do them well, this can be a common cycle. So we may be engaged, we have a high activity level, but we overdo it and our pain flares up. When that happens, we then rest for a few days, but because of that rest, we feel this pressure to make up for that. So then we overdo it again. And this kind of overdoing it, underdoing it cycle can perpetuate disability over time. We also focus a lot on thoughts and emotions in CBT. So pain is the experience of pain, but then the distress that's added onto the pain is really where we see suffering come in the really, emotion and deep emotion that comes along with chronic pain. So a CBT goal is to kind of recognize and reduce thought patterns that may exacerbate distress or exacerbate the pain response. And we do this through a series of techniques. So thought changing is something we can do. One is that we can challenge our worries. We come up with evidence or facts that support, do I know this will be as bad as I think? Is there anything I know about myself that will make it so that I can handle it? And then we also help individuals develop statements and thoughts that they believe, but are also more calm and supportive and facilitate coping a little bit better. So this flare won't last forever. I know I can get through this. I've gotten through this before. We also do a lot to support the family. And some things that we recommend in CBT are to really encourage the child to manage pain independently and praise those efforts. So as they're learning skills and techniques, we want them to try those first and then come to the parent or family for support. We also want to encourage normal activity during pain episodes, particularly if it's an episode of pain that's not associated with acute flare-up. And so the longer we're out of school or not doing things with friends, it becomes much harder to return over time. So with modifications, we want to continue to encourage that activity. And this one sometimes has people kind of questioning when we recommend to not ask about pain frequently. So the reason that is because we don't want pain to be kind of the primary focus of the child's day. And if the child happened to be distracting themselves with something and then a family member comes in like, hey, are you in pain right now? They might then turn the attention to their body and say, well, I wasn't noticing it, but now I am. So this doesn't mean that we can't talk about pain at all within the family. Rather, we may suggest that the child initiate that discussion, and or the family set up a certain time each day that's the pain check-in. So maybe after dinner, for example. In addition to those CBT components to help with just pain management and pain coping, there's other aspects of chronic pancreatitis that we can support with. So if we find situations where kids are having difficulty attending school, or they fear attending school because of pain happening, if there are problems with eating or sleeping because of pain, sad mood, hopelessness, anxiety, or outbursts, difficulties with friends or classmates, missing out on activities, and or having trouble following doctor's recommendations. So some children may be prescribed pancreatic enzymes or to follow certain dietary modifications, and that may not be always so easy for children. So as behavioral specialists, we kind of help work through some of those barriers. So a question is, how do I get CBT? So one thing that I recommend is to ask your local gastroenterology or pain management team for referrals. There's also a national database of multidisciplinary pain programs, and that will indicate also if pain psychology is involved. There's also a free app called WebMap, which is essentially CBT that has been translated into an app for people to kind of guide themselves through. It's a really excellent resource. There's also plenty of apps and websites to help with some of the relaxation techniques. These are some examples. I also want to point out the Comfortability website, which is run by pain psychologists and offers different ways to connect with other patients and families going through chronic pain, hosting chat groups and support for parents and teens across the country, and offers newsletters and other resources. And then these are books that I highly recommend and are all written for kids and their families. The first two are written by pain psychologists and experts in the field that really break down all of the CBT components for people to try to implement at home. And then this workbook on the end is full of different exercises and worksheets that kids and teens can work through on their own at home. Thank you.
Thank you, Kristin. Thank you to all of our speakers. I had a glitch for a moment with not being able to unmute my button. So I'm just going to take like a minute or two to summarize what I kind of could gather from the great talks that you guys gave today, and then go through some of the Q&A together as a discussion. I would start off by thanking all of you for a wonderful summary. And Dr. Husain, you summarized very nicely the overview of chronic pancreatitis by presenting a couple of cases, walking us through them, and then the definitions, how it's mostly relying on imaging, what is the best methods for diagnosis, and what is the typical pain of chronic pancreatitis, and how the importance of a team approach is really key in management. And then Dr. Goldschneider, you described nicely the differences between acute pain, acute recurrent pain, and how that could lead to differences between acute pancreatitis to recurrent pancreatitis, and then how could that become chronic pain in cases with chronic pancreatitis. So the patterns of pain are important to understand so that we can treat the patients appropriately. And then the goals of therapy should be to focus on the function, not while we want the pain to go away, but we shouldn't make it the focus to have the the pain be free. We really want to maximize function and quality of life while we're managing the pain. And you covered also the types of medications used. And then Dr. Rich, in conclusion, you showed us the role of non-medication, non-pharmacological therapy in terms of its role in the management for chronic pancreatitis. In fact, an aspect that a lot of centers even don't always have access to, or even families. So this presentation is a very nice resource because it does show apps and books so that we could educate the providers and families on how best to seek that out, and then how the impact of pain is on every aspect of life. You know, its function, its school, its work, it's the family, its emotions and stress, and the role of cognitive behavioral therapy, or CBT, and the reasons why we use it. So I learned a lot, and I think it's one of those areas where we can educate ourselves even from the questions that we get from our patients. And I do see that some providers, I can tell that they are asking for a child, so caregivers, but even for themselves too. So I welcome those questions. And if I may start, a question to Dr. Husain. It's, you commented on how we could, as gastroenterologists, start by treating, right? And we don't usually start with strong pain medications. That's until we refer them to someone like Dr. Goldschneider. But we could use pancreatic enzymes or steroids or antioxidants. Can you comment if any of these has been superior or shown promise in chronic pancreatitis so far, Dr. Husain?
Certainly. So there are, as I mentioned, and you highlighted, many treatments that are employed, and the question is, how effective are they? There are studies, few, to suggest that antioxidants are helpful to a limited extent in adults with chronic pancreatitis who have developed chronic pancreatitis due to causes other than alcohol. So we would extrapolate that in children they may be effective. And this is a prominent study that came out of India. Now, there have been other studies from England that have not shown it, but those, you know, presumably were in a greater number of patients with alcohol-related chronic pancreatitis. So antioxidants are relatively benign. I think they're worth trying. They could help. As far as pancreatic enzymes, definitely in the setting of exocrine insufficiency, and even if exocrine insufficiency is not clearly or unequivocally diagnosed, if a patient has micronutrient deficiencies, is sort of lacking some of the vitamins that the pancreatic enzymes would cause to absorb, then I think indirectly that could be the case for starting pancreatic enzymes and supplementing with those vitamins. Otherwise, for chronic pancreatitis, pain itself, there are ongoing studies to answer that question, and I think the jury's somewhat out.
Yeah. So far we go by, if there is insufficiency, we could do the enzymes, but other aspects for children are still out there to be tested for utilization. And that makes it, of course, a more of a challenge still, because we still cannot have a magic pill to say this is it, that could be promising to take the pain away. Thank you. Dr. Goldschneider, could you please comment on when do you consider TENS units in the management? I see a question from the audience on it. Where do you put it? But in general, when do you consider it?
It could be considered almost any time. It's a relatively harmless treatment. That is to say, you could be allergic to the stickum, you know, of the lead pads that go on the skin. But other than that, it's really fairly harmless. You can't put it up on the chest if you have a central line, and there's some limitations as to where you're allowed to put it safely. Mm-hmm. But you could try it over the upper belly. where the pain is. Sometimes kids will have referred pain to their back, and then they'll have some back spasm and stuff from that. So putting the lead pads on the back can be helpful. It's often useful to talk with a physical therapist because they're the ones that are most expert in using these. And there are a number of different settings, and some may work better than others for a particular person. So getting a little bit of education on all the different settings and the best pattern of placing it on through physical therapy is often worthwhile to do. But there's really no harm in putting it on for almost anybody, because if it helps, that's awesome. It's otherwise doesn't have much in the way, if any, of side effects. And if it doesn't work, it didn't do any harm.
Mm-hmm. Yeah, no, thank you. And it's good to know that this is one of the options. I wanted Dr. Rich, it's not really a question, but maybe give the audience a broad view of how you work with a pain MD specialist in the clinic, just so that we can have an idea of the model. And then when families come and see you, they know, or a similar, psychology, pain psychologist, what to expect.
Yeah, absolutely. So we usually start with a comprehensive evaluation that's identifying how pain has affected various areas of the child's life, as well as how it's affecting their mood, and then also get a sense of just any previous emotional or behavioral concerns that may be contributing to some pain amplification or exacerbation. Depending on how that assessment goes, we may recommend that the child follow up for CBT for pain, which could be anywhere from 4 to 6 sessions to learn the skills and get some competency there. And then if there are other issues that are happening, like severe anxiety, other depression or mood concerns, we'll work to find an appropriate provider to help intervene on those concerns.
Mm-hmm. Dr. Goldschneider, anything you would like to add from that model that Kristin mentioned?
No, I mean, it's a team approach. We overlap in the questions that we ask, and our goals tend to be similar. As I sort of put in that one graphic where I had the brain and the gut and the spinal cord and everything in between, we are whole people. We are not hurting body parts. So unless we address all parts of the pain experience, we're not doing right by the patient, and the patient isn't going to do as well.
Yeah. And the gastroenterologist is going to connect it all, right?
Well, exactly. Hey, it's a team approach.
Yes.
But I'll tell you, I'm going to throw this out there, and it's going to seem dogmatic, and in my case, it is. For the zillion years that I've had the clinic here, anybody that comes to my clinic that wants to see me and will not see a psychologist, I will not see. I think it is that important that we work together.
Yeah. No, thank you. I see Dr. Husain is typing an answer, so I'm going to ask it live. Maybe it's already typed because the panelists can see that. Dr. Husain, can you comment on the sphincter of Oddi dysfunction, and through that maybe comment a little bit on the ERCP for chronic pancreatitis? Because it's a big question, but it's very, very important.
Yeah, totally. It's 8 o'clock Eastern time, 5 o'clock Pacific time. And I would just make it brief. It's that sphincter of Oddi dysfunction involves a dysfunction of an area in the bile pancreatic tree called the sphincter of Oddi. 30 years ago, 20 years ago even, there were multiple papers that suggested that there was an association of sphincter of Oddi dysfunction with pancreatitis, including chronic pancreatitis. In fact, one prominent study from Peter Cotton's group, a group in the Carolinas, suggested that that chronic pancreatitis had a high prevalence of sphincter of Oddi dysfunction. The problem is in defining what sphincter of Oddi dysfunction is, and I probably have to leave it at that. It's a contentious diagnosis. So without having a clear diagnosis, it's hard to make an association, which is why I think every case needs to be individually examined.
Yeah, indeed. And it's really so personalized from the types of the genes and then the types of intervention and when do you apply it. And it's almost a patient by patient. It is actually patient by patient based. So there's a lot of exciting questions. Unfortunately, due to the time, we're 1 minute over, we're not going to be able to go through them live, but these will be banked so we can work as speakers with the NPF to answer them and get back to you all. I really want to thank our wonderful speakers for their presentations, informative indeed, and honestly up to date as medicine is advancing fast. I would love to also give a pitch for our patients and families who have called and the providers who want to learn more about pancreatic management. We really appreciate it, everybody taking an interest in learning on how we could together improve the quality of life of patients with chronic pancreatitis. And last but not the least, the NPF for all the role and effort in helping us work together for the benefit of our patients. Thank you all and have a wonderful evening.